woman's life cycle incorporates fertility, obstetrics, perimenopause, menopause, not just about reproductive care. That's a drop in the bucket.
Dr. Somi Javaid joins Allison Kaplan for a powerful Disruptor Live taping at the Let's Talk Women event in Minneapolis, focusing on advancing healthcare for menopausal women.
Do you know we lost $1.8 billion last year in the US economy because of underdiagnosed, untreated menopause? And we're facing up to a 10-year delay.
Where do you think better evidence exists, but women aren't getting the benefit?
The black box warning on vaginal estrogen. There is not a singular piece of data that supports that black box warning. But women won't take it, doctors won't prescribe it. For some reason, when it comes to women's health care, we're still archaic.
If there is a way to take charge, where do we begin?
Call it my 3 E's. Educate yourself, empower yourself. And if your doctor is not listening, exit. Expert care for menopause and sexual health, now just a click away. Virtual Care by HerMD offers longer visits, personalized treatment plans, and trusted providers, all from the comfort of home. Learn more at hermd.com. This episode was sponsored by HerMD. Content of the Disruptor podcast is for informational purposes only and does not constitute medical advice. Please consult your healthcare provider for personalized guidance regarding hormone therapy and all your medical decisions.
Behind every breakthrough in women's health is the same question: who decided it was worth funding? Today, we're going to talk about the money, the medicine, and what it will take for more women to get care that actually fits. Please keep track of all your questions because we will take some time at the end to pose them to Dr. Javaid.
Good morning, everyone. I am Dr. Somi Javaid. I am a board-certified OBGYN, a specialist in menopause and sexual health care, and I am a clinician at the intersection of evidence-based care, patient experience, and innovation.
Very good. I'm Allison Kaplan. I am the Director of Innovation and Engagement at the Minnesota Star Tribune here in town. We are here today to get past the buzzwords and get into the real work of building solutions. So let's jump in. It's such a pleasure to be here with you this morning.
Amazing to be here with you.
Yes. So let's start with a quick diagnosis. Let's do your 1-minute diagnosis of women's health in America right now. What's better than it's been and what's broken?
So it's broken for patients and providers, but what's better? Awareness, eradication of stigma and shame, and no more complacency. This generation is not going to suffer anymore, and they're not going to apologize about asking about their sexual health care. What's broken? Oh my God.
Do we need a little more time for that one?
Days. Not enough data, because we weren't included in clinical research trials until 1993. Lack of funding. Less than 2% of female founders get money. If you look like me, it's less than a 0.5% chance, but I've been able to raise $40 million to date. Reimbursement. A male and a female equivocal procedure. A doctor, if I perform that on a male procedure, I get paid 3 times as much. So you're worth 1/3 of a man to your insurance companies, and we all pay the same premiums. Want you to think about that. Female leadership. I see all the mouths opening. Yeah, this is the battle we have. Even though we outnumber men in the clinical workforce and have better outcomes, like you're more likely to die if your surgeon's male, sorry to the men in the room, than female, but we are not given those leadership positions, those decision-making seats, and lack of education. Right now, there is 1 trained provider for every 32,000 menopausal patients. What? Yes. And do you know how much of your life you're going to spend in menopause? 40%. Yes. Where are the doctors? So thank you all for raising your voices, showing up, writing the checks, voting for the right people, listening to the podcast, reading the books, watching the documentary. That's great, but so much more needs to be done.
So much more. That's what we're here to talk about today. Thank you for that overview. So let's dig in a little bit on the funding issue, shall we? Because raising $40 million is no small feat. What do you think is the most misunderstood part of funding women's health by founders, investors, and the public? What do we need to know?
The most common no I hear is, well, I've already invested in a female healthcare company. I'm like, well, they do period care. They do obstetrics. Or, well, you know, when Maven hit it big, that's great. They're like, Maven's got the menopause market covered. Do you know we lost $1.8 billion last year in the US economy because of underdiagnosed, untreated menopause? No, it's not covered. And oftentimes when I see a patient, I'm her 8th or 9th visit, and we're facing up to a 10-year delay. In the United States, we are a modern country where we can't diagnose women like for endometriosis for 10 years. And I think the other thing is for founders, you can have product market fit, you can have a solution for the problem, but unless you have a warm intro, it is still nearly impossible to raise money. So those of you sitting in those positions, I got to meet a lot of them last night, make those warm intros for those founders. We need them. I was a girl from Ohio. I was told I was a dinosaur because I was in my 40s. And they were like, you have no ties to Silicon Valley. It's funny, my investors did end up being both global and from the West Coast, but I needed those warm intros. And that's how I was able to raise so much capital.
Well, can you talk a little more about that? I mean, getting those warm intros and getting in those rooms. And I mean, you are doing that while you're also a physician and you're a mom and all these other things. Like, how did you begin that process?
Humility. I knew what I was really good at, but I also knew what I wasn't good at. And I leveraged my networks and I asked for help. I was like, listen, I know how I bootstrapped my company, kept it profitable for 7 years through COVID. I have women coming from 35 states and 3 countries. This is a blue ocean opportunity. I learned investor speak. It was like going back to school again. But I also taught them my speak so that they could understand what I was seeing in exam rooms and operating rooms and translate that to the boardroom. But I had to humble myself because I was at the top of my game as a doctor. But who was I as a founder and a businesswoman? An unknown. So networks, I reached out to my friends who had done it. And they were like, oh my God, yes. Let me help you put a pitch deck together. What's a pitch deck was what I said. Now I look at them for a living and help other people. But yeah.
Yeah, now ChatGPT can help a little bit with
I
that.
know,
When you say,
I didn't have that.
Right? Yeah, it's fascinating though to think that here you were a doctor, and like you said, at the height of your career, and that didn't matter in those rooms. I'm curious, as we have more events like this, and as we do feel like we're in this kind of menopause moment where we're talking about this more, is it getting it all easier when you're in those rooms with investors?
For sure. There's less red faces and less like shifting of the eyes, and they're much more willing to listen to the conversation. More companies are definitely getting funded. I think we need to see a couple of successful exits. That is what I'm hearing from investors, is they want to see a couple of these companies get to profitability and have a successful exit or acquisition. And so that's what we need more of. So definitely more conversations are occurring. I am getting sent more pitch decks from VCs who want to understand and learn. Plus, I think they're understanding that a woman's life cycle incorporates fertility, obstetrics, perimenopause, menopause, and end of life. It's not just about reproductive care. That's very important, but that's a drop in the bucket when you look at our life phase. And we all in this country, women, we live longer than men, but we live those years in very sick health. So we have protracted illnesses and then we die. I want to be dancing up mountains when I'm in my 80s. I don't want to have broken bones. I want to have a healthy heart and an
Amen.
intact mind. Yes. Right. And I think that is where we can move the needle. And women are the CEOs of their healthcare and their households. And we are the decision makers. So if we have the money and we have the decision-making capability, why is that not translating?
Can we talk for another minute about being a woman of color? You touched on this a little bit, but I don't think we can possibly overstate it. It's hard enough to walk into those rooms with VCs. I'm guessing when you do, it's still primarily men. And then add to that being a woman of color. What has that experience been like for you in raising money?
I didn't think of it as anything because my parents raised me to be colorblind and to just do things based on my ability, and anything was possible through education. I noticed when, yes, I would be the only brown or minority woman in the room at pitch after pitch after pitch. And then as I became a speaker and a mentor, I would have other physicians or other women who looked like me just say thank you. Thank you for being up there, because you're the first one that I've seen that looks like that. And if I made that difference for someone or gave them the power or the belief that they can do it, then I feel like I've done my job.
That's great. And are you finding more women in the room among VCs?
I am, but I feel like those women are under just as much scrutiny as I am as a founder. Because when I got in the room with women, I'm like, yeah, I'm gonna get this check because she's been through it. She's been a patient. She's experienced these symptoms. I don't have to get her to lock on as much to the story. But then a lot of them who are very honest shared that, they're one of, just a few women maybe on their team, and their investments are scrutinized. And so the cycle is just, it feels like never ending. So all of my capital has come from men.
Seriously?
Yeah, we had a nice Forbes headline that said HerMD when we first raised, and I was actually really mad about this headline, but now I get it. Now I get it because the writer did me a very good service because it was clickable. HerMD raises $10 million for women's sexual health, and it's funded by men. And I was like, why did you have to say it that way? But she did me a brilliant service because people wanted to read that. Yeah.
Interesting.
But I took it as I was like, why'd you have to say that I had to go to the dudes to get the money? And she's like, well, the dudes do hold most of the money. And I was like, yeah, they do. Yeah.
Well, and I guess you could look at it like, isn't it great that men are evolving and that you are educating them about what a good investment looks like today?
And I will tell you, with the storytelling, I was actually shocked. Because people are like, wasn't it crazy talking about women's sexual health and vaginas and menopause to men? Yes, sometimes when I had the really young tech male investors, they would they glazed over, turning red, and I just knew. I knew at that point the check's not coming from you. So, but some of them, it was so endearing, they would share personal stories of maybe what their mother suffered with her fibroids, or what his wife was going through. And when you use data and outcomes, but you weave it together with an incredible story, and I had so many stories because I'd been listening to patients for over a decade, and you bring that to them, it's very hard for people to say no. And so that was my job, to take those stories from the exam room, from the operating room, and bring that to the investors so they could understand beyond the data what was happening and the impact that they were going to make by giving me a check.
Amazing. So if there are investors in the room, just people with some extra cash, or corporate innovators, right? Anybody? What should we be thinking about investing in right now? when it comes to women's health? What would you suggest?
So there's a lot of companies entering into healthcare, which is amazing because it's making it accessible. I don't want women to wait 10 years to get a diagnosis. But I told you guys about the educational gap. Not only have women not been educated about their anatomy or about their medication choices. Like, I'm gonna ask you all something. Who knows what Viagra is? Raise their hand. Okay. Who knows what Addy is? Okay. Oh, very typical. Addy, add your interest, first ever female sexual health care drug, took 6 years to get to market. Less than 5% of providers know about it, less than 1% of the general public. Viagra, 6 months to market, under emergency use authorization. It was a national emergency, people. Yeah, open that mouth. Yes, it was. Women had to wait 6 years, and yet providers still don't know about it. They still don't prescribe it. And just this week, I had a patient come to me. Her husband's Viagra was covered. She wanted Addy. Do you know what the insurance company's response was? Denied. Oh, no, not even just that I would have been okay with. Denied, go to marriage counseling first and fail. Oh, yes. And fail. And then we'll cover it. I'm like, but then failing is what? You're divorced. What do you need the medication for? And he's got Viagra, so he's good. So, yeah, I think, so to fix all of this, like, it's great that all these companies are popping up, but where are the providers getting trained? Not in residency. I trained on my own dime and time, and I train providers. So we launched HerMD Academy. We used it 10 years internally, have outcomes posters on how it improved patient experience, but also trained providers in real life. And so we're doubling down on the business unit, and we're going to launch it externally. So AI-powered education solution. You want a blue ocean opportunity? I'm the girl who told people 10 years ago menopause and sexual health care was gonna be big. I'm telling you that's where you write your dollars. And yes, I am fundraising right now, and I have term sheets. So, hey, that's the other thing to the founders in the room. Worst thing you can hear is no. Fine, move on. Like,
you can't be afraid of the no, right?
You can't be afraid.
We'll send the basket around the room, just in case. We're here to help you, Somi.
Yeah, and I'll use it to get more patients, better care. Yes.
That's right. Well, speaking of that, you're a Midwestern girl. I'm a Midwestern girl. Talk a little bit about how women, particularly in the Midwest, might be falling through the cracks when it comes to healthcare.
It's so sad. So I get to sit on, I'm a little bit of a geek, and I love innovation, and I love learning about smart tampons, and now there's smart vibrators, and there's minimally invasive devices, and there's head-to-toe screenings for cancer, and there's a multi-site early detection test for cancer that tests over 50 different types of cancers. How many cancers do you think you all are screened for? 3. Breast, cervical, colon. And I still can't get you all to get even those 3 done because you're telling me you're too busy taking care of everybody else but yourselves. So these innovations test for over 50 different types of cancers. They're available. They're on the market. Why haven't you heard about them? Because insurance doesn't cover them. And they're not affordable. So I get to sit in all these really cool rooms and learn about all this really amazing innovation that can actually prevent death. And I then sit in telehealth and listen to women who don't have access to get a pap smear. So women in the Midwest, the tier 2 markets, the ghost cities, that's what's happening. And so we have to bridge that gap of innovation, early detection, and advances that we have in healthcare and make it accessible for not just the rich, but for everybody.
Right. Amen to that. You have pushed for longer clinical visits, for more screening, some of the things you're already talking about. Where do you think we can get the most bang for the buck? Where are we most likely to see the outcomes improve?
Yeah, so I say that time is one of the biggest enemies of healthcare. You are supposed to tell your entire personal health history, including your sex life, to this doctor, gain some rapport, get naked, get an exam, get dressed again, and then understand your diagnosis, risk-benefit analysis, make a decision, decide if it's covered by insurance, and do that all in not 15 minutes. I was teaching a class a couple months ago. Some doctors are down to 5 to 7 minute appointments. That's not even a quickie. Like, what is that? That's like, yes, I'm writing a book with the same wit and humor, girl. And my podcast is called The Disruptor. That's what we're taping right now. So I mean, I have to be honest, we have to laugh. It's gotten so bad. But I think, that's the issue. So if we can fix for the time, how do we fix for the time without charging concierge rates of $3,500? That's great if you can afford it. You have to get insurance companies to reimburse for the time, because most doctors I know want to spend the time. We need the time. If you don't give doctors time, they're also burning out. Women are leaving. They're leaving even though they have better outcomes, because there's a pay gap, and because they don't have mission-driven work, because they honestly feel like they're in a McDonald's drive-through of gynecology and they cannot provide the care that women deserve. And I remember, we set up longer appointment times for providers and gave them education, and the first thing they said to me is, "Thank you for giving me the space to finally practice medicine the way my patients deserve." So that's how I think we can fix medicine.
That's great. Is there any place where we could save time? Is there anything that you think is happening in that visit that maybe isn't essential, that should be spent on the conversation or something else?
Yeah, I don't think that. My biggest regret in high school is that I refused to take, oh God, I'm gonna age myself, keyboarding, typing. Because I was like, why am I gonna need to learn to type? And then EHR came along, electronic health records. There are physicians that retired. We still don't, we at HerMD have AI scribes. And we also have a third-party call system. I want my doctors and providers well-rested, getting their sleep, so they're wide awake and able to take care of you, and I don't want them buried in administrative paperwork. That EHR doesn't benefit the doctor, doesn't benefit you. It benefits the insurance companies, it benefits the hospital system. Sorry for those of you who are with hospitals in here, we love you and need you too. But we're data entry clerks. My husband's an oncologist, and because he refuses to take his computer in the room, because you've just been diagnosed with cancer. You want to look your doctor in the eye, right? He's talking to you about life and death. So my husband comes home every night, we have dinner, and until about midnight, he sits there with his dictaphone 4 nights a week, doing his notes, because he doesn't want to rob his patients of that time. Is he paid for that? No. In fact, he's fined if his charts aren't done on time. And so that's where we're wasting time. Why do not all doctors have AI scribes?
Yeah, why don't they?
It's so cheap. Hospitals don't pay for it.
It's crazy. Yeah. Let's use
Let
the technology that's available.
Your doctor should go in, focus on you, help you with the decision making, do the procedure, and they should be out. They should not have to do anything else. So if you can remove all of that administrative burden, guess what? You'll benefit too, because you'll get more one-on-one time with your provider.
Okay, let's shift a little bit to the clinical tests and medicine. Where do you think better evidence exists, but women aren't getting the benefit of it?
I think there's a lot of myths out there, and I think maybe an announcement is happening today. So you guys all know about the black box warning on vaginal estrogen, right? So there's a black box warning on estrogen that it'll call as endometrial cancer, heart attack, and stroke. Do you know that there was never a singular study showing that showing the vaginal estrogens do this? Okay, so what the FDA did, I'm so getting a call tomorrow, is they took the data from systemic estrogen and progesterone, which is completely different, slapped that warning onto vaginal estrogens. So there is not a singular piece of data that supports that black box warning. But women won't take it. Even after I talk to them, they're like, oh my God, did you read the package insert? I go, yes, I hope you didn't. I did, oh God. Okay. Number two, doctors won't prescribe it. So women are dying and getting hospitalized from urosepsis, complicated UTIs. So we're actually doing harm by an institution that is meant to protect us and usually does a really good job. But for some reason, when it comes to women's health care, we're still archaic. So that's one, the myths that are out there. The two is, like I said, the innovations that are out there. You know, we're barely getting screened for 3 cancers, and we have capability to screen us from head to toe, and women aren't getting the facts about their options. Advanced cardiac screening. So my own mother nearly died at the age of 45, presented with left arm pain, shortness of breath, and chest pain. Had 2 sisters die before her and my grandmother all before 50. She had an abnormal EKG and was told, it's too much caffeine, children are stressing you out. She ended up almost dying, and I call it the call that led to my calling. We were sharing. I went to Northwestern to be a journalist, and then I switched to pre-med because I was like, I love surgery, I want to do this. And then my father called me and he said, Somi, you need to come home. And when your father calls you and says just a few sentences, so I went home and my mother had been rushed for emergent quadruple bypass surgery. She survived, thank God. It didn't end up being stress or caffeine. It ended up being 4 blockages, including a 95% in her widowmaker. And the surgeon came out and told us if the heart attack would have come, she would have died. And so I can't tell you today how many women are either told, you have high cholesterol, you can't take hormones, or you have high cholesterol, eat better and come back in 6 months. Are they told about lipo-A and ApoB and HSC reactive protein and a coronary calcium score that you can get for $95 and you know your chance of developing cardiovascular disease in the next 10 years? Preventative data that you guys can then use to make curated decisions and maybe prevent a heart attack? How many of you have had any of these decisions? I'm a gynecologist. I'm supposed to know about vaginas, not hearts, but I do it because no one else is doing the work. So this is what is happening. And no one's talking to you about your brain health either. Yet we're the ones getting dementia, right? Do you know that you have estrogen receptors in your brain? And so a lot of women don't want to take hormones because they're like, I don't have symptoms. I said, do you know what's happening to your brain? We don't optimize glucose metabolism the way that we should. So then we start to use our own brain as fuel. And so we see atrophy or thinning in our brain separate and distinct from aging. And we think this is the reason we're more likely to get dementia, ALS, and MS. So when a woman says to me, should I take hormones? I don't have any symptoms. I'm like, what about the invisible symptoms? They're like, tell me more. How's your bone? How's your brain? How's your heart? I don't know, no one's checked. So women aren't being educated about what to ask and what metrics they need to know.
I might need to leave the stage to make a doctor's appointment.
My next opening is December 31st, but I know that I have openings that day, so yes.
Oh my goodness. I mean, that is real. Yeah. I mean, I think the whole idea of like you're only treating symptoms, and if they aren't, I mean, nobody's talked to me about that.
Yeah.
It's crazy.
You know why?
Why?
Because in this country we profit from disease. So we chase it. I want you all today to make a promise that we are going to move to a mindset of preventing disease rather than chasing it.
Incredible. One more question before we open it up to everybody else. If there is a way to sort of take charge of that 5 to 7 minute, hopefully 15-minute appointment that you get, and to start advocating for yourself? Like what, just give us some language. Where do we begin? What questions should we be asking?
Call it my 3 E's. Educate yourself, okay? So learn about it. There's some great online sites, there's social media groups. Talk to your girlfriends, it'll help eradicate the taboo. Empower yourself. Like, don't take no for an answer. No's not in my vocabulary. I'm sure you've picked that up in the 40 minutes we've been together. And exit. My God, if your doctor is not listening to you, I can give you all the language in the world, or if they're not trained, nothing's gonna happen, friends. Exit. You have my permission to break up with your doctor if they are telling you that you're too old for hormones. Or I had a doctor the other day, he told my patient, he compared sex to skiing and then told her...
Wait, what? Wait, what?
Yes, he was a skier and he was somehow trying to endear her and talk to her about sex. And he's like, well, why would you want testosterone? That's a male hormone. I don't prescribe it for women. And I was like, your ovaries make it, girl. Yes, testosterone can be good for a lot of patients. So I will tell you this, nobody knows your body better than you. Not even me, who's studied the human body you know what your normal is, you know when you're off. Believe that voice that tells you something's wrong. Don't let anyone second guess you. And use words like, I have been tracking, I have noticed, I typically. And the other thing I will say to the poor doctors who are trying to do the right thing and slammed in those 7-minute appointments, pick the thing that is bothering you the most and focus on that. You are never gonna get your head to toe symptoms, not in today's market. Are you gonna get everything covered? So be willing to go back again as long as that doctor is making you a partner in your healthcare journey.
Thank you, great advice. I wanna, we're gonna do some questions now. We have many, what a surprise.
Hi. Thank you both. This is incredible. Again, the second session of the day, and we're already like, wow. When my mom was going through a kidney transplant, we had to document a lot of things on a chart in between appointments. Is there something like that out there, and I'm sorry if there is and I just don't know it, where we can track a 30-day cycle and actually have data to look back at ourselves, not even in front of a physician, but ourselves, to say, I had 5 of 30 days that were positive. I had 6 days that were low energy. I had 3 asks for sex and declined, whatever that is. I didn't. No. And what are the resources?
So for general head to toe health, I don't know of any, but like for menopause, perimenopause, menstrual irregularities, there are a lot of trackers. Women are very concerned, given what's going on politically, I'm gonna behave, about putting their information out there, but there are some private trackers that you can use. I'm sure they can be applicable to general health conditions. And I will tell you, physicians who are truly engaged and want to help you, when patients bring me that, it's not the eye roll. It's like, thank God, like I have data, and that actually saves time. Oh, you already brought in your labs that you had done from someone else? Great, let me look at them and let's come up with a plan together, because I can actually write you a prescription today. So, but keeping that data is so important, particularly if your doctor leaves or something happens. A data wallet, I know that there's a global company creating something called a data wallet, so I would check that out specifically for healthcare. And I believe they're launching in the United States, but it's called Data Wallet.
Hi, thanks so much. Question to dig in a little bit more about brain health. You just mentioned this, but this is really important for me, looking at my mom and my grandma who've had dementia, wondering if you have any resources we could look up ourselves, check out about that estrogen receptors in your brain, glucose metabolism, please.
Yes, so Lisa Mosconi is an amazing neuroscientist and a researcher. Number one, she was in the M Factor documentary. I was too, but she talks about it. She's got 2 books out. I think one's called The XX Brain, one's called The Menopause Brain. Her books are amazing about talking about brain health, what you can do to preserve your brain health, and actually to explain what is going on with the neurochemistry and the changes. And even, I love some of the stuff that she talks about how like your perimenopause is this like zone of chaos, and that's why women feel so emotionally maybe unstable or irritable, but we actually gain empathy and emotional regulation on the other side. And so the good news is there is some upside from going through perimenopause and menopause. But she's the one who talks about these isolated estrogen receptors. And then Rhonda Viscal, she was on Oprah. She is also, and she's based out of California. She is doing some prolific research on the female brain, particularly in midlife.
Hi, thanks so much. This is inspiring to hear both the education and your own story. So I'm CEO of Flight. We're a first-line conservative treatment for female urinary incontinence, outcomes comparable to surgery, typically prescribed in primary care or OB-GYN. But I really wanted to, if you could dive in a little more deeply to the comment you made about how coverage is part of the equation. Far too often women have to pay for treatments out of pocket when men wouldn't be paying for comparable treatments out of pocket. We are really grateful to Minnesota payers because we've got really strong coverage in Minnesota and in the Midwest, but more nationally, even when you've gotten HCPCS codes from CMS, it's a journey to get coverage nationwide from some of the big payers. I wonder if you could talk a little bit more about that and how we encourage payers to look at the evidence and not be so quick to say no.
So what I would encourage you to do, and I've done this for a couple of innovative devices, and I actually heard about your device last night and would love to have a conversation with you, is we have to eradicate a couple barriers. Innovation dies without uptake, so if your provider is not going to learn about it or do it, you're never going to hear about it. We have to train providers on it. But as far as getting payers to pay for things, like, because I brought in-office ablation, that 6-minute procedure you can do, and got them to pay me for doing it in the office. We brought in Sonata, which is an incisionless treatment to treat fibroids, and you can also do that in the office. But I collected data. I used medical students. I was scrappy. And then published either posters or outcomes. And then I got on the horn with the chief medical officers of United, of Cigna, and I showed them the outcomes. And I said, okay, you can spend $25,000, $30,000 to send the patient to the hospital to have a hysterectomy, but look, I can do this for X in the office and look at the outcomes. Reduce pain, reduce suffering, reduce downtime for her, cost savings to you, but everyone wins. But somebody's got to be willing to do the studies and collect the data. And that's what I did. And I made it very cost effective for partners. I was able to get medications and devices that were held back by prescription available over the counter by partnering with these femtech companies and collecting data across our locations. And I was willing to do it really low cost. Because I had leveraged medical students who want to, work and are learning. So there's scrappy ways. We're women. We're smart. We can figure it out. A study doesn't have to cost $1 million.
Gotta love those medical students.
Love those, and they loved it too. They call me. They're like, "Oh my God, you know what? From that study, I knew the answer in my class. So thank you for that. It's a win-win."
Absolutely.
Hi. My name is Lindsay. I am not a doctor or provider. I'm just a 45-year-old woman who's really grateful to be hearing all of this and learning all of this. I have a question just about weeding through all of the noise. 20 years ago, we were unfortunate that we didn't have all this information out there, right? And I remember my mother going through hormone therapy, and then in 2002 going off of it, and it was very black and white. And now we are fortunate to have all this information out there, right? And all of these different ways through, whether it's social media or just women are talking about it more. But now what's unfortunate is that there is so much noise about supplements, about hormones, about protein and weight-bearing activity, that we are just overwhelmed and confused. And I guess my question is, when I think about all of this noise, where do I go? What's the first step that I take? Do I go to my primary care physician? Do I go right to my OB? How can I weed through all of this, still be willing to, learn all of it and absorb all of it, but take the right step towards what's right for me?
You want a menopause-trained provider. So it doesn't always have to be a gynecologist. It can be your primary care doctor. It can be a nurse practitioner. It can be a multitude of different providers. That provider should not only talk to you about, hormone therapy, risks, benefits, and alternatives, but there are non-hormonal options. There's lifestyle, like you're referred to, lifestyle. There's direct-to-consumer products. There's supplements. There are so many things that are involved in the menopause care plan. And for me, I curate a plan and I meet the patient where they are. So you want someone who's going to meet you where you are. And I also help patients make those decisions with data. Like if you have high cholesterol, I'm going to say, okay, well, maybe we need to get all these markers and see where your cardiac health is right now before you can make a decision. So we get the facts and then we figure out a plan together. And a lot of times, yes, it is lifestyle modifications, it is medications. And you're right. When I look at everything out there, when you talk about hormones, bioidentical, conjugated, compounded, systemic, low dose. I mean, there are so much nomenclature out there, it's confusing. There's a lot of snake oil salesmen out there as well. Menopause Society has certified providers, and you can look them up by zip code if you don't know by word of mouth. So that's a great place to look.
That was my one follow-up question, is how many doctors today are, menopause experts, other than the amazing women here today? Not
enough. It's still that 1 to 32,000 ratio. So there's not enough of us yet. Every year, more and more are getting trained. But not enough yet to meet the demand. And that's why, they may not be certified, that's fine, but if they've gotten the training, that's okay. The certification just means you've paid for the test. And to be honest with you, I haven't paid for the test because I'm like, I teach people. Like, I don't need, and I did a 4-year OBGYN residency, but you want people who are associated with Menopause Society or who have had some type of training in menopause and perimenopause, because none of us got it in medical school or residency.
That's a great takeaway. So that's what we should be asking when we make that appointment. Okay, we have a question in the back.
Hi, my name's Heidi, and I'm a physician assistant, or associate, I guess they call us now, in family medicine for the last 25 years. And I have been blessed to work in a system where I get a half an hour with the patient, which is great. But I wanted to reiterate something that you said that is so important for us providers. I'm very into preventative health, and as I've aged with my patients, a couple years ago, I'm like, I got to figure this stuff out. And so I was lucky enough to work on getting menopause certified now and all this stuff. But the biggest thing that you guys can do when you come in for your primary care, your yearly visit is a yearly visit is to do all your preventative stuff and get everything updated, like your mammogram, your colonoscopy, or, update your meds. We have all this health maintenance stuff we have to do. So when you have a bunch of other stuff, we can't do as good of job with that other stuff if we have more time. So I try to talk to my patients about what are the most important things that you need to talk about. And especially with this hormone stuff, that's a whole nother visit. And sometimes we'll get labs and then bring them back and talk more about it. But we want to work with you and we want to have that time. But it's also awesome if you guys could understand and not have 25 things you want to talk about, that you'll get better care if you're okay with coming back and getting more time for each thing. So I just wanted to say that because it's important.
And some women, they present, thank you for that. And then for you, I wanted to say, never say, I'm just a 45-year-old woman. Never start a statement that way, ever. You have to walk in empowered, I'm a 45-year-old woman and I matter. So yes, and thank you for that as well. I agree. We do have to break down the visits, unfortunately, because of the system.
So as a doctor, if you're not going to think I'm a crazy person if I make 3 different appointments because I have various issues I want to discuss.
No, and I would rather do that with you so that I'm not doing you a disservice, and I can answer all your questions, break down all the data, and we can talk about all the optionalities. Like, you'll get much more out of it, and it renders a lot less of a delay.
Hi, thank you so much for all of this really great information. A couple questions or just notes. Though the ADDI is only for premenopausal and not postmenopausal, there's a warning on the website. So I'm just wondering if there's something coming out for postmenopausal women. And
so it's not contraindicated. It was just the original studies included premenopausal. So it's indicated or on label for pre. There's tons of data, including mine, that's been presented in postmenopausal patients and breast cancer patients. So it's not a warning because it's not a contraindication. It's just indicated for. But I know for a fact that they're going for the secondary indication to include menopausal patients because that has scared so many providers and patients from taking it in the menopausal years. But I would say over half of my patients on ADDI are menopausal.
Awesome, thank you. And then secondly, I think one of the biggest things facing women of older age, or as they age, is the shame that comes upon, so a year ago I started hormone replacement treatment, ended up in the ER for swollen leg, and the shame that came from the attending who, was 35 and male, literally silenced me. It was so humiliating from his question, well, why would you be on that? And so just the whole thing of trying to not internalize that and advocate for myself and to be able to speak and have the language to speak to why I would be on it. And the mental and the brain, the physical, as well as the emotional. So thank you so much.
No, and I would say to you, number one, I'm sorry that you had that experience. I hear it every day. It's what gets me up in the morning when I want to quit after been doing this for 2 decades. But I would have said back to him, I'm sorry that you feel that way, but I didn't ask you for your opinion. That would be my language. And I'm going to give you guys all a fun homework assignment. There's a question over there.
Well, this is a bit of a public service announcement, also based on life experiences. You sort of glossed over, because that's really not the focus of the talk at the moment, or even our day. When you said, when you talked about urosepsis and complicated UTIs and chronic UTIs. Urosepsis and complicated and chronic UTIs are no joke.
No.
And I didn't even know that that's what I was dealing with for over 2 years. And in 2024, was suffering with UTIs almost monthly. And of course prescribed the same antibiotic that's always worked, until it didn't anymore. And my primary physician, and I'll name names to the extent that I'll say Health Partners in Woodbury, someone that I loved, trust, respected for 10 years plus. I was on this treadmill with the same treatment. She was on vacation. I met with an available doctor, and happened to be a male. And he said, so what about vaginal estrogen? I said, what? Game changer.
Game changer.
Yeah.
And I want you guys to write this name down. I don't want it because they're going to tell us it's time to go. If your doctor won't write it because there's a black box warning, there is a localized estrogen or localized hormone product that does not have a black box warning. It's called Intra Rosa, okay? Does not have the black box warning. Teach your doctor that. All of you tonight are going to take a test called the FSFI, Female Sexual Function Index. 19 questions will teach you all about your sex drive and your sex life, and if you're having any issues or you don't need any help. And then your next assignment is take it into your doctor and see their reaction. And that's how you know whether or not you're with the right provider. You guys have been a blast. Thank you.
Dr. Somi Javaid, thank you.
I hope we have fun.